Hello everyone, welcome to this short tutorial from Pathology Made Simple at ilovepathology.com. Today let's learn a very interesting topic in gastrointestinal pathology, that is how to differentiate between gastric and duodenal ulcer. So basically the overview of this topic will be, we will enumerate the differences between gastric and duodenal ulcer. So before that, let us see what is this peptic ulcer disease. Peptic ulcer disease is basically a chronic mucosal ulceration. That's because of gastric acid secretion or pepsin, that affects predominantly the duodenum and the stomach, and it is almost always associated with Helicobacter pylori infection, non-steroidal anti-inflammatory drugs, or cigarette smoking. In the earlier videos, I had discussed in detail about the Helicobacter pylori infection and its associated gastritis and other manifestations. So let's move straight into understanding the differences between gastric and duodenal ulcer. The first one, distribution. So duodenal ulcer is actually more common. It is around 4 times more common than the gastric ulcer. The duodenal ulcers usually occurs in around 30 to 60 years of age group, whereas gastric ulcers are usually common in the age group of more than 50 years. Females are more commonly affected when you see gastric ulcers, whereas the duodenal ulcers are more commonly found in males. Now, what is the location of gastric ulcer? The most common location of gastric ulcer is on the lesser curvature. So these are the most common locations of gastric ulcers. These are categorized into different types. One is type 1 ulcer. This is the ulcer usually present on the lesser curvature. This is type 1 ulcer. Type 2 ulcer, it affects both a part of duodenal mucosa and gastric mucosa. The pre-pyloric ulcers are the type 3 ulcers, whereas the ulcers present in the cardiac region is known as type 4 ulcers. So basically, the predominant location is the type 1 ulcer, that is the most common in the lesser curvature. Whereas duodenal ulcers are most commonly located in the first portion of duodenum. That's the superior part of the duodenum. This is also referred to as duodenal bulb. Over 95% of the duodenal ulcers are located in the duodenal bulb. Approximately 90% are located within 3 centimeters from the pylorus, and usually, they are usually less than or equal to 1 centimeter in diameter. They're basically smaller ulcers. If you look at the shape of the ulcers, gastric ulcers are usually, saddle-shaped ulcers. That's, the part of the ulcer on the anterior wall and the part on the posterior wall. Whereas the duodenal ulcers are usually round, and the ulcers on the posterior wall tend to be considerably larger than those on the anterior wall. That's because, those on the anterior wall, if it grows larger, they are likely to perforate. This is one of the reasons why the posterior wall ulcers are larger than the anterior wall ulcer. Now, what are the common causes of gastric ulcers and duodenal ulcers? Both of them, it has the same etiology, H. pylori associated and non-steroidal anti-inflammatory drug usage. Whereas other risk factors for the development of duodenal ulcers include Zollinger-Ellison syndrome, various malignancies, vascular insufficiency, and even a history of chemotherapy. Now, what are the clinical features? How do you differentiate between gastric and duodenal ulcer? Well, the common features are epigastric burning and dull aching pain in the epigastric region. That's a common symptom. Whereas the associated pain, that generally intensifies after meals. The food aggravates pain in gastric ulcers. Let us understand why this happens. So whenever the person consumes food, when the bolus of the food enters the stomach, immediately what happens is that there is constriction at the level of pyloric sphincter. So constriction of pyloric sphincter, that results in retaining of the food within the stomach. That's very essential because of this is very important for the food to be digested with the addition of the digestive enzymes and hydrochloric acid. So imagine the patient with gastric ulcer, if the food bolus is inside the stomach itself, and upon that you have lots of acid being secreted, and obviously this acid tends to irritate the ulcer. That's why the pain intensifies after the consumption of meal, immediately after the consumption of meal. In contrast, the duodenal ulcer, the pain improves after meal. Let us see what happens in this case. So this patient is having duodenal ulcer here because the food is contained within the stomach because of pyloric constriction. There is no acid being released into the duodenum. There is no food in the duodenum immediately after consumption. That's why if the patient is already symptomatic, the pain tend to improve upon consumption of food. But then what really happens after 1 to 3 hours, the pain starts appearing. That's because the pyloric sphincter relaxes after a few hours, and then the bolus of food passes from the stomach into the duodenum. Upon that, it also has acid along with the food, right? That's why the pain starts 1 to 3 hours after eating in duodenal ulcers. Usually these are the patients, they eat, sleep, and then suddenly in the middle of the night they wake up with pain. That's very characteristic of duodenal ulcers. Another important manifestation or a feature of duodenal ulcer is that these patients have radiating pain. The patient with duodenal ulcers will have pain which radiates to back, and which is not so in the case of gastric ulcers. Anorexia, nausea, vomiting are more common in gastric ulcer than duodenal ulcers. What about the weight loss? So obviously the patient tends to lose weight because they eat less due to fear of aggravating pain. Whereas duodenal ulcers, the symptoms tend to improve post meals, and that's why they go on eating. That's how these patients, sort of gain weight. So weight loss is more common in gastric ulcer. Weight gain is common in duodenal ulcers. Hemorrhage is most likely in gastric ulcers, whereas less likely in case of duodenal ulcers. If at all there is hemorrhage, they manifest as hematemesis in gastric ulcer. If at all there is hemorrhage in the duodenal ulcer, they manifest as melena. That is passage of black colored stools, right? Now let's move on to understand how these ulcers look. Both the ulcers have a similar appearance. They are usually sharp, punched out ulcers, as I told you earlier. They are rounded or oval orifice to the ulcer crater with overhanging margins. Now, what do you mean by overhang margins? That means at the edges of this ulcer, the mucosa terminates abruptly. This is called overhang margins. The size of the ulcer might vary. See, in contrast to this, look at this malignant gastric ulcer or gastric cancer. The edges are very regular. Okay, the margin, heaped up margins, what you see here. So this is a very classical case of gastric cancer, where unlike the abrupt termination of the mucosa in benign gastric ulcers, in the malignant gastric ulcers you do have a lot of heaped up margins. That's gastric cancer. But sometimes both gastric cancer and gastric ulcers, if they are smaller in size, it's very difficult to appreciate it clinically. It is very difficult to differentiate between cancer and ulcer clinically. That is the reason why it is always essential, it is always necessary to do a biopsy to rule out cancers in these cases. In a very classical case, you can differentiate between gastric ulcer, benign gastric ulcer, and gastric cancer, but not always. Now let us understand the features of ulcer floor in a typical chronic gastric or duodenal ulcers. The muscularis mucosa, that's usually thickened and extends right up to the wall of the crater. This is a crater, this is a wall of the crater, and this crater can extend deeper till the muscularis. Sometimes it can even perforate, right? So classically there are 4 distinct zones which was originally described by Ashkenazi. The first zone is a necrotic debris, where you find layer of purulent or fibrinopurulent exudate. The second zone is an inflammatory zone, where you find lots of non-specific acute inflammatory cells. The third zone is a granulation tissue zone, whereas the fourth one is a zone of fibrosis. So 4 zones. One is necrotic zone, inflammation, zone of granulation tissue, and zone of fibrosis. This is a classical histological appearance of a chronic active gastric ulcer or a chronic duodenal ulcer, whatever, peptic ulcer basically. Now what are the complications? Perforation, as I told you, it's more common in duodenal ulcer. The posterior ulcers are the ones which often perforate. They perforate into the pancreas and then they cause pancreatitis. Whereas gastric ulcers perforations are less common as compared to that of duodenal ulcers. The most important one is the risk of malignant transformation. The risk of malignant transformation is evident, is there in gastric ulcers, whereas it is extremely uncommon or even nil in case of duodenal ulcer. So how do you treat? Treatment is basically the same for both of these ulcers. You consider eradication of H. pylori, and then neutralization of gastric acid primarily with proton pump inhibitors. And you have to withdraw these non-steroidal anti-inflammatory drugs which may interfere with mucosal healing. And finally, if it is not responding to the medical line of therapy, obviously the patient will be subjected to surgical therapy. So that's the end of understanding the differences between gastric and duodenal ulcer. Hope you have liked this video. If you have liked this video, hit the like button. Do comment if you have any queries, or if you find any other differences, you can add them in the comment section. Don't forget to subscribe because I'm coming out with many more interesting videos, and do share if you find this video useful. Thank you.